Okay, great. Welcome everyone to this session on cancer and universal health coverage, entitled Tackling Cancer Through Sustainable Health Systems. The session is organized by MSD, which is a leading biopharmaceutical company that specializes in cancer, vaccine, cardiometabolic diseases, and infectious diseases, including Ebola and HIV. My name is Camilla Knox-Peebles, and I'm Chief Executive of AMREF Health Africa UK. And I'm super happy to be joined here by some great speakers and eminent leaders in cancer in Africa, who I'll be introducing in a moment. First, I just wanted to give you a little bit of a sense of what the trends are on the prevalence of cancer in Africa. Cancer is on the increase in Africa at a speed unparalleled by other terminal diseases on the continent. Currently, deaths from cancer in Africa account for more than the total number of deaths caused by malaria, HIV, and TB. Over 1/3 of all cervical cancer deaths globally occur in sub-Saharan Africa, though the region represents only 14% of the female population, of the world's female population. 90% of cervical cancer deaths globally per year occur in low and middle income countries with the highest burden of deaths in sub-Saharan African countries. These figures suggest the need to prioritize cancer and direct further resources and increased resources towards cancer control and management. And integrating cancer detection and surveillance in UHC and in primary healthcare in particular as part of UHC is one of the essential ways to reduce the number of avoidable deaths from cancer. And we'll be discussing in this session other strategies to reduce cancer deaths. Finally, while some progress has been made on the continent with nearly 50% of countries having national cancer control plans, there are gaps in actually implementing these plans and still limited understanding of the extent to which these national cancer control plans are meeting the needs of the population in terms of early detection, care, and treatment of cancer. Now, I'm delighted to be joined by Benda Kithaka, who is the CEO and founder of Kilele Health, which specializes in empowering cancer survivors and caregivers to use their lived experiences for advocacy in cancer prevention, stigma reduction, and to improve their quality of life. Benda, welcome. And you'll be setting the scene and telling us a little bit about the experience of the cancer patients you work with and the cancer survivors that you work with. Over to you, Benda, and a very warm welcome.
Thank you, Camilla, and good afternoon and good morning, everyone joining us today. I'm delighted to be speaking about the patient experiences in Africa. I have worked in this field for 9 years now, 10 years if you count this year. And in my work, we experience, we encounter, and we come into contact with various cancer patients as well as survivors, as well as caregivers at the community level. And I'm here just to paint a bit of a picture of what the scenario is on the ground. Listening to Camilla today, you've heard about late diagnosis of cancer patients in Africa. You've heard about statistics, about the high burden that we have in Africa of both incidence as well as mortality. You've also heard about the gaps that we have in UHC, as well as the national cancer control plans. That's at the data and statistical level. At policy level, what we get to see and the data that we get to hear about. But what about at the community level? What are we experiencing? If I can tell you about our patient experiences, we see stigma, we see fear of cancer, we see lack of basic information about signs and symptoms, we see resource limitations into the access for care, as well as poor outcomes for our survivors and caregivers. If I can illustrate with an example, let's take a woman, we'll call her Jane, not her real name. She's in her home watching television or maybe listening to radio as she's going on with her work. And this is a real life example of a woman. It's just the name that I've changed. Jane is doing her housework as she's listening to another woman talking on television, talking about the cough that was dismissed. It was persistent, but people said, oh, you know, you could be having the cough because you're forever milking in the morning. Or another woman who has been dismissed with her bleeding because she's told it could be you're bleeding in between periods because of hormonal imbalances. Or another woman who is talking about her breast that has been swelling and she's been hiding it. All these are cases that we see on television. The thing about Jane, though, is she is fortunate to have that TV, and therefore she can be able to watch and she can be able to reflect on what she's hearing. And this brings to mind for her what she's been going through. Jane has been going through intermittent bleeding over time. She has had a foul discharge that she has been trying to hide with basic hygiene. Jane also has gone to hospital a number of times and been sent away with either antibiotics to clear the infection or with knowledge that she's being told this will clear by itself. Real life example. And for Jane, when she's watching this woman and hears her say that for her it was a cancer diagnosis, this time armed with that information from the television or the radio, Jane goes back to the healthcare system to seek a cervical exam, and this time she actually insists on it. Jane is fortunate, she has a TV. What about that woman deep in the village who only gets to hear about her health when she's in the community in a gathering? And regrettably, nowadays with COVID-19, we don't have as many gatherings in the community. And therefore, many women could be going through what this woman has been going through, and they don't have that information. What this story about Jane tells us is, we have our women and our men living with early signs and symptoms of disease. Regrettably, they may not even know that it's symptom of a disease that could be cured at an early stage. They have endless visits to the doctors with sometimes misdiagnosis. Sometimes the doctor is stretched because he has to see all the other diseases that have been mentioned, malaria, TB, diabetes, and therefore they have very short time to spend with Jane or the other woman to understand their situation. These women and men have to travel long distances to access basic diagnostic care, let alone treatment for cancer, which is invasive. Regrettably, by the time they get to the healthcare system, the cost is very high, the chances of recovery diminish, and regrettably, because of the cost, they have so many harambes in Kenya, that means so many fundraisers that they have to go to so that they can contribute for people to be treated. Unfortunately, some patients and some families get impoverished. And regrettably, it could have been prevented with early detection. Ultimately, poor outcomes, impoverishment, what we like to call in these settings financial toxicity. But the reality on the ground is that what people are seeing at the community is too many deaths. Regrettably, that could have been prevented. What they are seeing is stories of pain, anguish, poverty, and all the things that we want to translate and say the woman presented late. The question I want to pose to all of us is, before we go blaming the woman or the man who has presented late, how well is the healthcare system serving the community? How well is this woman guaranteed that she will be able to access the necessary treatment without financial hardship? What is promised in the UHC? What I see as the real need at the community is meaningful inclusion of persons living with cancer because they know where the shoe is pinching. It is equity and ownership, acknowledging their lived experiences so that we can show where the healthcare system is either serving or not serving the community. And this can inform policy changes. What I see is us concentrating as well on the quality of life beyond treatment so that we can have people who are changing the narrative at the community level. If the community is seeing death all the time, they will be afraid. If they see empowered community members who are coming back and saying, this is my journey, it need not be your journey, it will be a different ballgame altogether. And lastly, what I see is the need for quality of life focus, whereby we are removing stigma reducing fear, and inspiring others to take the challenge for prevention so that we can prevent what is preventable and allow our healthcare systems to have to deal with invasive disease that could not necessarily have been prevented and therefore needs treatment, access to care, and policy decisions. I think if I stop there, Camilla, I have set the table for us to continue with this dialogue about UHC and cancer care and how we strengthen our systems. Thank you so much.
Thank you, Benda, and thank you for so powerfully illustrating the reality of some women. And you're working particularly in East Africa, aren't you? So,
yes, correct.
Really, really powerful illustration through that example of Jane, and also the differences at community level between communities. So I'm just going to pause here to introduce the rest of the panel, who I will be giving a first round of questions to. So in no particular order, let me introduce you to Mrs. Bindiya Sadarangani, who is the Director of Lakeshore Cancer Center, which provides cancer surveillance, care and treatment, and is based in Lagos, Nigeria. Welcome, Bindiya, and if you could put your video on, that would be fab. And we also have Dr. Christina Stefan, founder of the African Medical Research and Innovation Institute, which has just completed a very important piece of research on cancer control in Africa, which we will hear a bit more about in this session. Then we have Mr. Zwelitu Bashman, who I will refer to for short as Zweli, who is the Managing Director of MSD South Africa. Welcome, Zweli.
Thank you very much, Camilla.
And finally, Dr. Pebo Barango, who is Medical Officer on Non-Communicable Diseases for the World Health Organization. Dr. Pebo, if you could put also your video on, that would be fabulous. Thank you so much, all of you, for coming, and welcome to you all. Welcome, Dr. Pebo. So we just heard from Benda a powerful example, and she threw, I think, an important question back to us, which is, how well is the healthcare system serving the community? So turning to you, Christina, and based on your findings in Africa, how would you answer that question? What is the status of cancer control and cancer care at a community level and elsewhere?
So indeed, we have heard, and it was obviously the scene has been set about tackling cancer care, about cancer care in Africa, and obviously about the inclusion of the universal health coverage. But I would like to change a little bit the narrative and not being really now as a founder of the African Medical and Research Innovation Institute, but maybe at times the voice of children with cancer, being a professor in pediatric oncology, a pediatric oncologist by profession. So representing maybe the voice of children with cancer, and not only of the children with cancer, but obviously behind those children having their mothers, their families, sisters, grandmothers, the whole society. But I would like to start perhaps with two other thoughts that I had listening to my colleague, who very eloquently demonstrated and shared with us the story of a possible patient. So what I would like actually to share with you is related to the African Organization for Cancer, for Research and Training on Cancer. In 2015, I became the first woman from the African continent to be elected president of AORTIC. So for those in the cancer field, AORTIC stands for the African Organization for Research and Training in Cancer. And for me, that moment had a special meaning because it was a sign of change. It was a sign of change on the African continent, and I felt together with many other colleagues, because we are talking about the African continent, so obviously a very large continent with a large population, that Africa was really ready for change. And of course, we can talk about change in terms of supporting gender equality, but it was much more than that. Of course, I felt honored, but also humbled when contemplating the task ahead, as there were numerous far-reaching changes needed for greater progress in terms of cancer control in the region. So there were many projects, there were many initiatives, but I would like really to underline one of them, and I think it has in this context a special meaning. And this is actually the publication of the first book on cancer control and universal health coverage in Africa. So I think, it will be important for anyone who has any interest in cancer care, UHC, for anyone who is working in cancer control, to read this book. I have sent the link, so it is freely accessible to all. A book which was written by and for African leaders, for healthcare specialists, for survivors, for advocates, for many others working on cancer control in Africa. A book which critically analyzes the present cancer environment on the continent, while also looking at the future. And when I'm saying looking at the future in the context of universal health care. So again, the aim of this book was to highlight and to share existing information related to cancer care, and also to disseminate plans and measures to advance cancer care in the context of UHC. One lesson, or the lesson that emerges, is not only that a major difference can be made by reducing the incidence, the number of total deaths, improving the management, increasing the survivorship for many cancers in Africa. But let's just take one example: cervical cancer, a major threat to women's health on the African continent, can actually be eliminated. The second research that I want very briefly to share with you relates to a survey looking at the cancer resources on the African continent. An initial survey was done 5 years ago, and now we decided to repeat it, to have a follow-up and to see how could we compare 5 years ago with what is happening now. So as key findings, obviously, as we would expect it, the estimated, and I'm talking about estimated, so not the real incidence, and there are no enough registries on the African continent. So estimated number of cases and deaths are still increasing. We've heard about national cancer control plans, not every single country having one, and those who do have, which do have a plan, not all those plans are functional. The efforts for cervical cancer prevention for vaccination are covered only in a small percentage. But perhaps in this context, I need to mention the efforts of the WHO, and especially the WHO local, AFRO, who initiated a systematic analysis looking at the capacity and the preparedness of the first 6 countries in Africa to tackle cervical cancer with the aim of eliminating it. And of course, there are some other challenges in terms of key findings, such as we still have only 1 pathologist per million inhabitants. So there are a number of labs which we do not have accreditation. There are only a few countries, and I'm scared to give numbers, out of our survey relieved that only 11 out of 52 African countries which responded offers NIH, so National Health Insurance, and many other challenges. what I would like to end perhaps this small intervention is related to the fact that despite all these challenges, which still do exist, and we need to see them and we need to talk about them, a lot of progress has been also made. At the moment, 88% of the African countries have chemotherapy. We have an increase of the number of radiation centers. They increase by 30%. So again, a tremendous effort between IAEA and the local AFCON. We have a better morphine delivery, and we have again an increase in the number of what I would say is one of the most resources that Africa has, and these are the healthcare resources, so oncologists, nurses, radiotherapists, and so on. Number of publications of cancer research has increased, education has increased. So on this time, as an oncologist, I would really like to also, perhaps see the full side of the glass and not only the changes. I mean, we're still far, but definitely progress has been made in the last 5 years. And of course, and a lot much more can be done in the future.
Thank you, Christina. That's really helpful. So whilst there are still huge challenges and you recognize those, you'd also like us to celebrate some of the successes and increases in resources going to cancer. Brilliant. Turning to you, Dr. Prebo Barango, just in terms of what Christina's just said, how does that reflect in your work with WHO? Can you tell us a little bit more about both the challenges and the successes that you're seeing?
Yes, thank you very much, Camilla. I think the two previous distinguished speakers have set the scene properly. So the key issues with cancer in Africa is that there is late diagnosis. Late diagnosis, as highlighted by Benda in our opening intervention, could be due to poor health literacy on cancer, or it could be due to challenges in the health systems to diagnose appropriately. And Christina had actually highlighted the challenge with pathology. But also, apart from the late diagnosis means that the outcomes for cancers, even cancers that are curable in other parts of the world, still have very, very poor, dismal outcomes in Africa because they are diagnosed late. And then, from what Benda has said also, there is significant out-of-pocket because cancers are usually pay either for diagnosis or for treatment, or for both of them in most countries. So there's significant out-of-pocket. And lastly, we have a significant input from infectious causes of cancer. So those are the challenges key challenges we have in cancer in Africa. But it's not all lost. Within the context of universal health coverage, if we remember that universal health coverage includes access to healthcare that one needs at the time one needs it, nearest to your house or near to your place of residence, and without you incurring financial burden, hardship in accessing this. And for WHO, cancer control is actually one of the key important health issues in terms of non-communicable diseases. And so our interventions or our actions with cancer has been really, really comprehensive, spanning from prevention and early detection to treatment, care, and palliation. And so in terms of, for example, the non-communicable disease global action plan has key specific targets that member states signed to deliver by 2025, but now it's been extended to 2030. And that includes cancer incidence and mortality to reduce it by 25% by 2025. And we know that not many countries are getting to that. Now, in order to redouble the efforts, WHO has also come up with what we call signature solutions, which aims at highlighting key issues, supporting the setting up of targets, and that usually would be an avenue to mobilize resources. And of these signature solutions, we have key ones for cancer. So, for example, you have the Global Initiative for Elimination of Cervical Cancer as a public health problem. That was ratified by the World Health Assembly last year. And in Africa, like Christina mentioned, we are supporting member states to achieve the elimination of cervical cancer. Cervical cancer in other developed countries is no longer a public health problem because cervical cancer is preventable. We know what causes cervical cancer. We know the actions to take to prevent it. What we need are the willingness and the systems to be able to deliver these interventions across prevention, early detection, and treatment. We also have the Global Childhood Cancer Initiative, because I mean, the cure rate for children with cancer is over 80% in developed countries. But across our region, unfortunately, it's the cure rate and survival rate for children with cancer is dismal, less than 20–30%. In some countries, it's even much worse. And so the global initiative on childhood cancer to improve survival, and we are supporting member states in the region with partners to ensure that we improve survival rate for childhood cancer. It's actually not complicated. The medicines are not expensive. It just ensures to train healthcare workers to be able to detect early. And of course, we have other initiatives that are not focused on cancer itself, but looking at the risk factors for cancers. We also have, if I can just chip in quickly, the global initiative on breast health and breast cancer. So these are specifically targeting and focusing on cancer. And the importance that WHO gives to cancer is actually attested to the fact that there has been 2 World Health Assembly resolutions on cancer control. In 2005, there was one, and in 2017, there was another.
Thank you. Dr. Prebo, you've just frozen. Can you hear us?
I hear you. Can you hear me?
Yeah, I can. Yeah, thank you. I think you've
it's
made
my video.
Points. Thank you so much, and really helpful to hear about some of the initiatives as well that WHO is and has launched, and also reminding us of those 2 World Health Assembly resolutions. Again, you know, it obviously is central to the work of the WHO. Just moving on from what Dr. Prebo Barango was saying, I'd like to turn to you, Zweli, just as a working for MSD, which is a major pharmaceutical company that focusing on cancer care. What do you see as the key focus exactly that's needed? What would really help you in terms of addressing some of these challenges that we've heard? And preventing and I think key here is this piece around early detection. But just focusing on your work, that would be great.
Thank you very much, Camilla. I think after hearing the previous speakers, I'm even more convinced that as MSD, we're actually on the right path. At MSD, our focus is always on the patient, but we are conscious that the journey towards broadening cancer care on the continent is a multi-pronged problem that requires multi-pronged solutions. And so for us, it all starts with education and awareness, both at a healthcare practitioner level as well as with patients. We spend close to 100% of our promotional budgets on educational materials and healthcare practitioner educational programs such as this one, because we firmly believe that these engagements actually have a direct impact on improving patient outcomes. We also have now a strong focus on driving patient awareness. We believe patient awareness is a key pillar to driving health-seeking behavior and encourages early detection. In fact, earlier this week, we rolled out a partnership with 3 doctors in South Africa to conduct educational webinars on social media, on HPV vaccinations and cancer prevention. In these sessions, we actually had upward of 16,000 people engaging, asking questions. And this goes to show that people actually do have a deep yearning for more information. And we feel that we've got the responsibility to provide it in the most user-friendly and accessible way possible. In parallel to our efforts with regards to education and awareness, we are consciously trying to capacitate the healthcare system through our social business innovation investments. And now what these are investments that we make in noble and novel healthcare causes that can improve healthcare delivery across the continent. Towards the latter part of last year, we announced a 12 million rand grant to Unjani clinics in South Africa. And this partnership will certainly have an impact in strengthening the primary healthcare system at a community level. And just yesterday, the Uganda Cancer Institute launched a patient navigation program. And through the program, cancer patients are provided personal guidance to ensure timely cancer screening, diagnosis, treatment, and supportive care. In order to set up this program, UCI actually partnered with the American Cancer Society and then received a financial grant from the MSD Foundation. We firmly believe that a strong primary healthcare system that's accessible at a community level has a direct impact on early detection of cancers, as well as other diseases that may pose a challenge to the person. We also spend quite a lot of time engaging with legislators related to issues of how we can ensure a favorable environment on the continent for the introduction of innovative medicines. These engagements focus on how we can responsibly shorten regulatory lead times. We're also focused on how we can co-create a favorable legislative landscape to ensure that intellectual property rights are taken into account. And actually, these are critical for the continued investment in innovation. What we do spend most of our time on, though, is solving for affordability and creating viable access solutions. Recently, we've partnered with Hanover Re to co-create a private health insurance product that would serve as an affordability solution for immuno-oncology in markets where IO therapy isn't fully covered by existing insurance system. This could serve to supplement potential co-pays or cover the full treatment costs depending on what type of health insurance the patient may or may not have. Similarly, we've got partnerships with Gavi that ensures large-scale HPV vaccination rollouts across low and low-middle income countries. And we do all of this in an effort to drive cervical cancer elimination across the continent. Often the biggest barrier to access to innovative medicines in countries is country-specific legislations that do not necessarily allow for the implementation of access solutions. So we are constantly engaging with legislators on this matter. Mm-hmm. This isn't a challenge that's just experienced by MSD, but it's something that cuts across all manufacturers of innovative medicines, and this is something that as a collective we are working through. Most importantly, we focus on innovating and inventing for life. At MSD, we ask ourselves 2 very important questions. How many people are we helping? How much help are we providing those people? And the aim is to maximize on both those aspects.
Thank you. Thank you, Zweli. Thank you. Really strong points there. Strong primary healthcare, favourable legislative landscape, and also some form of private health insurance product that you talked about and enabling. I'm just very aware of time, so I'm going to move on to Bindiya. And you actually run a cancer care and treatment center in Lagos in Nigeria. Can you tell us a little bit, just even picking up on the point around the legislative landscape, the policies that you need to ensure that people come to the centre early and so on and so forth? What can you tell us a bit from your perspective? What is needed?
Thank you so much, Kamala, for having me here. Gosh, a lot is needed, but I'm so happy to be here and to hear of all the initiatives at play in Africa in general. So I'm really excited. In the last 7 years that Lakeshore Cancer Center has been opened, and it being the pioneer cancer treatment and screening center in the most populous country in Africa, we've seen a lot and we've experienced a lot. And there's been a big change, I must say, in the 7 years that we've been here. The stories that Benda mentioned resonate so greatly with us, even in a metropolitan city like Lagos. We see stories of late diagnosis on a daily basis, and mostly due to lack of access to diagnostics, some education, and missed diagnosis in a lot of cases. She also touched on financial toxicity, as well as, which is also a huge concern. So universal health coverage would definitely benefit us and the continent. I think universal health coverage is a huge undertaking, as there's a spectrum of need when it comes to tackling cancer. As Dr. Prebo mentioned, he said that, there's different needs from screening to diagnosis, to treatment, to palliative and pain management, vaccinations, supportive care, and so forth. So it's just, there's a wide spectrum of need, and it's a bit overwhelming for most to actually focus on one, because we can't just focus on one. We have to have impact on all those aspects to actually see a big change. Just to highlight a few points of change that as a private center, cancer center in Lagos, we would like to see, and I think would have a maximum impact based on the experiences we've seen in the past. I think the main one, all the panelists have touched on this, is education. We can't emphasize that enough. For healthcare workers, for the general population, we have seen the need and the excitement for education, and we've seen that healthcare workers want to build, they want to know more, they want that, we need to increase capacity, and they've understood it and they're ready to learn. But I think government policies need to enhance that and increase it and make it more accessible for training institutes to come into countries and ensure that we can actually build capacity, because as everyone's mentioning, cancer is growing on a rapidly increased basis, and we just don't have the capacity in the continent, I think, to tackle the burden of the disease. So, and we've seen it in our small center, where we have hosted a number of trainings in the last few years, and we've seen the enthusiasm, we've seen the change in the medical professionals, we've seen the change in the general population. They're more cancer aware, they're more health aware. They just know more about their health, and they want to know more about their health. So we've seen this here. Obviously, this is, again, Lagos. There is the rest of Nigeria, where we still have a lot of work to do. We'd also like to see a bigger focus on screening. Early detection and treatment is actually key in making this sustainable. The earlier we catch it and the earlier we treat it, the lesser the financial burden is, and the more sustainable the universal health coverage is. So we can actually, that the funds that go into that can actually be used in a much better way if we catch these cancers early. Because if we are, as we all know, that if we treat the cancer late, you're dealing with a lot of different treatment options, and a lot of times the outcome is very, very poor. The next one is access to diagnostics. We need more pathologists. That goes back to, again, capacity building. I think everything I'm saying goes back to capacity building. If we don't detect it accurately, it's harder to treat, and then you're actually ending up palliating instead of treating and curing a cancer. The current national insurance scheme in Nigeria covers only 5% of the population. So we hope to see it being more accessible and it to cover some more treatments. As a private sector, we also would like to see policies and legislations to assist us in funding these hospitals. So there are a lot of private investors interested in Africa as a continent, interested in investing in Africa and healthcare in Africa, but the environment, the economy, the government needs to make this more conducive for us to allow them in and actually help us. Because once they invest and once we have bigger hospitals and more capacity, we can actually reduce cost of treatment and in turn help patients for longer. I think, also tax breaks for medical equipment, medications. There's a lot of red tape when it comes to bringing in new medications, and cancer medications are changing on a regular basis. So to bring in the new immunotherapy drugs, there's a lot of red tape involved. There's a lot of cost implications involved that a lot of the average Nigerians cannot afford. And so if we can get ease access to that, increase steady power supply is something that's so basic, but it would be great to have access to steady power supply so that we can actually treat on a regular basis and the financial burden for the hospitals is less. If, allow us to be training centers, so involve the private sector quite more, because if we are training centers, we can actually increase the capacity. And those are basically my thoughts in a nutshell. Nigeria has been great so far in trying to implement it. We're one of the countries that has a national control plan. And in the last 2 years, what's happened is that Nigerian states have adopted the national control plan and creating their own plans. And this is actually headed by the first ladies of Nigerian states and has gained a lot of traction in the last few years. So what they are planning on doing and focusing on is a lot of accurate diagnosis being made at the primary care level. So the secondary and tertiary hospitals expend their resources and time on treatment. So it decreases the burden in the country. There's also funds allocated in the Nigerian budget for catastrophic health fund to cover cancer treatment. So we're hoping those come into play this year. They've been earmarked, but we're trying to find the government's trying to find the right place to put it in, because there's a lot of need. There's just only so much money that can be done. So that's it. That sums it up for me.
Thank you, Bindia. That's really, really helpful. And again, your point around education for the general population, something that's really mentioned, that Benda mentioned, whether it's TV or other media, how do we get to put the message across in what you need to look for as an individual? Bigger focus on screening, catch a cancer early. Again, all of you, all the panelists have mentioned this, lessening red tape. And both really and yourselves working in the private sector, you've mentioned the national, the insurance, and that actually only very few people in Nigeria, you were saying 5% have access to it. So I'd love to hear more about sort of innovative, low cost solutions. But before I do that, I'm going to try and get some questions from panelists, if that's okay. And there are a few. So, and we've got about 12 minutes left. So I'm just going to ask this one. What are the real contributing factors for late stage presenting of those patients in healthcare, and how many? And then there was a question to you, Dr. Prebo in particular, about how many member states have signed the WHO guide towards cancer in our context of Africa. So what are the real contributing factors that mean that patients come so late, I think, at the to healthcare, I believe is the question. So who wants to answer that? Any of you, just put your hand up. And then a specific one for Dr. Prebo. Benda, Sweli, go ahead.
Yeah. So I think, in terms of patients presenting late for healthcare, there's a myriad of different issues. I think many of the people within the panel have spoken about the importance of healthcare being accessible at a community level. That's something that really encourages patients to have this health-seeking behavior. Someone else, I think, Benda, you mentioned around the importance of having more stories of survival, because the more people hear about oncology and cancer, often always resulting in death, inadvertently people are going to have, a resistance towards looking into healthcare scares that they may have. And this is not something that necessarily only impacts and affects people that are not educated. I know in my personal family, my father passed away, of colon cancer. And the detection happened at a very late stage. It was called at stage 4. He was someone who was very well educated, had an understanding of, how his body was feeling. And upon engagement with him post the diagnosis, one of the things he said, I knew something felt funny. But because it was something that's never been a constant conversation or within media that he engaged with, it was never something that he felt that he needed to look into or ask questions about. So I do think those are the important things that need to be looked at.
Thanks, Willie. Benda, you were going to come in as well, and I've got a great question here that I want to field, but we'll hear from Dr. Peba on the World Health Organization. Benda, go ahead first.
Okay, so besides what has been mentioned as the causes of late presentation, I want to also pose that probably we need to address the information gap with the element of having community health volunteers as well as community health workers at the lowest level of the community with a higher suspicion of disease. If we equip them with the knowledge, they are also members of the community. When they go back, as they're having conversations at the community, they will have that hands-on information and that hands-on experience to be better able to guide the community to own their health. At the end of the day, if we want to go far, we all need to take everyone with us. And one of the things that I know is at the community level, we all want the same thing, empowered communities. And the best way to equip them is with information so that, as Willie says, we are able to take on that information as early as possible. People are aware, self-aware. They don't wait for the scream. They hear the soft voice telling them something is wrong, and they can take action at the same time.
Brilliant. Thank you, Benda. Really, really good point. Dr. Peba, can you just answer how many member states have signed the WHO guide towards cancer in our context, in the context of Africa?
Yes, it's all, thank you very much.
Dr. Peba, we've lost you.
Hello?
Yeah, you're back.
Hello? Yes. So am I still audible?
Yes, yes. Sorry, we lost you for a second.
Okay. So all the member states actually were part of the World Health Assembly resolution on cancer. And so all member states have done it. But let's remember that just to contribute to the other question, the bedrock of UHC is primary health care, meaning that they are closest to the people. So if we empower the primary healthcare workers to be able to detect early signs and symptoms of cancer and be able to refer. So it means strengthening the PHCs and strengthening the referral mechanisms, because we know that many people actually present early, but misdiagnosis that has been mentioned because the healthcare workers don't have the capacity, either because of knowledge or capacity to test and diagnose. So one of the things that WHO is doing also is to ensure that we include cancer care into the UHC benefit package. That means that the countries identify the key cancer activities or cancer interventions, and they are included as part of the UHC benefit package, meaning that it will improve a lot of access to the rural communities and people to be able to get care and not be worried about the financial cost, because we know that the cost of access to treatment contributes to people deferring treatment. Over.
Brilliant. That's such a good point. Thank you. Thank you, all of you, for those points around the importance of primary healthcare, community health workers, PHCs, and which is included in the cancer care and UHC package, in the UHC package. So really, really important stress and focus on that group of health workers. Thank you. We have an excellent question here around, and I'll read it out. Among the reasons behind cancer increase in Africa are aging and healthy lifestyles, lack of physical activity, unbalanced diets and tobacco consumption, as well as infections, HPV causing cervical cancer, Hep C causing liver cancer. What could be the coordinated approach to suggest to better fight these causes?
So the first thing to do is to develop a costed national cancer control plan, which includes all this prevention, early detection, and have key stakeholders be part of the development of the plan, so that everybody's, so tobacco control is not necessarily a health sector led intervention. Unhealthy lifestyle and healthy diets and physical activity is also not in the health sector. So it needs a multi-sectoral approach to develop and implement those plans.
Thank you. Any other thoughts? Christina, do you want to come in? We haven't heard you for a while.
Yes, for sure. Definitely, I think it's a very interesting discussion. I would say much more than that. So number one, of course, a national cancer control plan is essential because it's sort of a baseline from where you start. But we have assessed quite a number of national cancer control plans. Unfortunately, we do not want them to end in a drawer somewhere, you know, in an office. And it is a big difference between a national cancer control plan, program, or a strategy. And there are, again, few basic elements that a national cancer control plan needs to contain. And again, WHO has a very clear methodology. Despite that, quite a number of these national cancer control plans, they lack it. So number one will be to look at the incidence. Look at the incidence, so that means number of new cases, prevalence, the number of cases that they exist, and the deaths. Unfortunately, even today in 2021, not every single country has a registry. So we still work with estimations. Estimations are very good, are excellent. They are done by, you know, specialist statisticians, but they do not represent the reality on the ground. So we cannot take, out of all the countries that are in Africa, there are only 5 that their registries made it to IARC, which is the International Agency for Research on Cancer, part of WHO. And again, one cannot really take from the neighboring countries, such as Zimbabwe, which has a good cancer registry, and transplant it, let's say, to South Africa, because the pathology is different. The behavior is different. The people are the same, but they are not the same. You know, cultural, ethnicity. I mean, we are not talking just about one population. Only if you look at South Africa, we are the rainbow nation. So, you know, we have 11 different languages. People that have different, you know, traditions, customs, which we need to respect, because each of them is extremely important, you know, for that specific group. So from the registration which we need to enforce to the major type of cancer, and then obviously one of the essential elements which is lacking in some or most control plan is represented by the budget. Because without the budget, without really knowing where and how much is it going to cost, the governments need to prioritize. Because cancer is so large, we can't cover everything. And I think, again, I applaud WHO with the 2 global initiatives. Cervical cancer is a cancer which can be prevented. We don't talk about advanced, we talk about an injection that can be given right to a vaccine from early childhood, so this cancer will be gone forever. And the second one, of course, I'm very passionate about that as a pediatric oncologist, is about children. About children, where WHO has this global initiative on 60 by 2030. That means an increase in the survival of childhood cancer in Africa to 60%, which is still not very high. As first world countries, we are talking, sorry, Dr. Prebo, I would say even 90%. He was mentioning 80%, I would say even 90%. We want to be there. Our children should live just as long as any other child in the world. So the fact that our children are born in Africa shouldn't be really, you know, the place where you are born, the place of birth should not dictate your chances of survival. So again, a fantastic initiative. And if we look at the 5 top cancers of childhood, the amount of money, the cost, because we've done healthcare, health economists, they worked about the cost of childhood cancer. It's actually very, very, very cheap. And I mean, the child has cancer, we diagnose, we treat, and then we give back to the society. A child is going to live and produce for the society for another 50, 60, 70, or even more years. I applaud again MSD, and I'm going to end here because I know time is running. I applaud the initiative of education. And it comes to my mind what one of the greatest leaders in the world, and of course that is Nelson Mandela, my idol, said, education is the most powerful weapon which you can use to change the world. And I think really focusing on that, we are going to see tremendous progress. Again, African culture has always been...
Christina, sorry, because we've literally got 4 minutes, and that was such a great way to end. Thank you so much. National cancer control plans are not everything. Data is required. You need data, you need a budget. And it would be great, actually, Christina, if you could share some studies on the investment in cancer, the ROI, the rate of investment in cancer. Yeah. So prevention and so on, like you talked about children, they're really important. Takeaway thoughts for the last minutes from Benda. I know you've been dying to come in, so please come in. And then Bindia and Zweli, and I think we've heard Dr. Prebo. So then go ahead, Benda. Literally a minute.
Camilla, my takeaway is in Africa, we say a boat cannot go forward if each rows in his own way. What we require is integration of services. Let everybody focus on growing in the right way. We want healthy communities that if they are empowered, they can be better able to take care of the economy. And to do so, we need to look at the woman, not as cervical cancer or breast cancer, but as the woman holistically, and invest in health for women, health for men, health for children, holistically, integrating the services and creating the knowledge base against which we can handle health. Thank you.
Thank you, Benda. Bindia, over to you.
I'll make this very quick. I said it before, and it again boils down to education. I think every panelist has mentioned this: education. We need to really empower the healthcare practitioners, the community workers, everyone along those lines, to make sure there's enough education out there, because I think that knowledge is power. And the other thing is data. I didn't mention it in my presentation, but the cancer registries, we need it for research. Africa is seeing different cancers than the rest of the world, but we're treating African cancers like we do with the rest of the world, and that's just wrong. We should be treating African cancers as its own people, as its own entity and its own treatment plan, and that's what we're seeing day in and day out, and that's my take home. And thank you very much for organizing this. It's been really enlightening for me as well to be hearing people from all over.
Thank you. And Zweli, for the last takeaway.
Yeah, thank you very much, Camilla. I think for me, the big thing is, UHC isn't an outcome that can be achieved by or owned by any one sector of society. Like most things, we'll only achieve it through partnership. I think businesses must continue to innovate, both process and product. Government must create a legislative environment that's favorable for the outcomes that we want to achieve, and communities must constantly be highlighting the areas of the greatest need. I'm a big fan of co-creation and co-investment. And so, you know, collectively, we have to continue doing some of the things that we are doing to get it working.
Great. Thank you. Thank you so much for a fantastic panel, a great discussion, a lot of thoughts, creative ideas on lots of different levels. I can see the questions were coming in. We weren't able to field them all, but hopefully the team can pick them up and answer. And we'll make sure that you have resources related to this session in the AHAIC conference resources. Please visit the auditorium and join the session of your preference following this. Thank you so, so much. And it's been fabulous to have you here. And again, thank you to our brilliant speakers. Thanks and goodbye.
Thank you very much. Bye-bye.
Bye.
Thank you. Thank you so much, and bye.
Thank you very much. Bye.
Thanks, everyone. Well done.